Now we will discuss about cilia structure and its functions. There are two types of cilia. One is motile cilia and second is non-motile or primary cilia. Motile cilia, its arrangement is a 9 doublet plus 2 singlet microtubules. This arrangement is called axoneme. So what is axoneme? It is motile cilia arrangement 9 doublet plus 2 singlet microtubules. This arrangement is called axoneme. Basal body located at the base of cilium below the cell membrane. Its structure is 9 microtubule triplets and no central microtubules. Its function is movement of fluid or particles across cell surface. Motile cilia, its function is movement of fluid or particles across cell surface. Key protein here is axonemal dynein or ATPase. It links peripheral doublets. It causes bending of cilium via sliding of microtubules. Coordinations, gap junctions synchronize ciliary movement. Non-motile cilia. Non-motile cilia. Its function is it acts as chemical sensor and it is involved in signal transduction and cell growth control. And its clinical relevance or defect may cause polycystic kidney disease, mitral valve prolapse, and retinal retinal degeneration. So basically, non-motile cilia it acts as chemical sensor for signal transduction and cell cell growth control. So polycystic kidney disease, mitral valve prolapse, and retinal degeneration are linked to defects in the non-motile cilia. Primary ciliary dyskinesia or PCD. Its inheritance pattern is autosomal recessive and it causes dynein arm defect. Dynein arm defect leads to immotile cilia and dysfunctional epithelial cilia. It is most common type is Kartagener syndrome. Kartagener syndrome is a combination of kine, kine, primary ciliary dyskinesia and situs inversus. It is it is most common type of primary ciliary dyskinesia. Clinical features of primary ciliary dyskinesia: developmental abnormalities, situs inversus, organs are reversed, hearing loss due to eustachian tube cilia dysfunction. Recurrent infections causes sinusitis, otitis media, bronchiectasis, poor clearance of debris, and pathogenesis. And primary ciliary dyskinesia is also linked to infertility in female, increased risk of ectopic pregnancy. Fallopian tube, it is due to fallopian tube cilia defect, and in males, immotile spermatozoa. Lab finding shows decreased nasal nitric oxide. That is also screening test. So we have discussed about the primary ciliary dyskinesia that is autosomal recessive. Sodium-potassium pump, sodium-potassium ATPase, its structure and its function. Sodium-potassium pump it is located in the plasma membrane. It is ATP binding site on cytosolic side. Cycle per ATP. Three sodiums are out. When three sodiums are out from the sodium-potassium pump, then pump is phosphorylated. Pentopotassium are in, then pump is dephosphorylated. So this is the cell membrane and here sodium potassium ATP pump is located. When the three sodium are out, so Pump is phosphorylated. When two potassium come in the cell, so pump is dephosphorylated. So this is basically function. These are function of sodium potassium pump. And now I will discuss about clinical relevance of sodium potassium pump. There is very important drug. Its name is digoxin. Digoxin, what it does, it directly inhibits sodium potassium ATPase. So digoxin basically directly inhibit sodium potassium ATPase and indirectly inhibit sodium calcium exchange that result increase intracellular calcium. When there is a lot of calcium inside a cell, that leads to increased cardiac contractility. So these are main functions of digoxin that directly inhibit sodium potassium ATPase and indirectly inhibit sodium calcium exchange that results in increased intracellular calcium and increased cardiac contractility. So key takeaways from our lectures are motile cilia, that is 9 plus 2 arrangement and dynein driven bending. Primary cilia, non-motile and sensory role. PCD or Kartagener syndrome, that is due to dynein arm defect that leads to immotile cilia. When cilia is immotile, that causes infections, infertility, and situs inversus. Sodium potassium pump. Sodium potassium pump maintains ion gradients and inhibit, that is sodium potassium pump maintains ion gradient that is inhibited by digoxin. When it is inhibited by digoxin, that leads to stronger heart contractions. So these are our main points here.